Well, first of all, thank you very much, Dr. Vargas, for this nice connection, and I'm very happy to be again connected with Queen Harry Hospital, where I have so many friends, and I visited several times, so for me it's a happy moment, let me tell you, in this very difficult and complicated moments in the world. I hope that everything is fine in Saudi, and I hope that everything will be fine along the following days. Okay, so following this, my presentation today is about surgery of glaucoma in modern corneal graft procedures. I know that Dr. Vargas and many others are interested in this topic, and this is a topic that we are dealing with it very frequently. It's an essential part of the education of the corneal surgeon, because the corneal surgeon deals with this problem very frequently. You will see how frequently it is the problem. And finally, it is one of the main reasons of corneal graft failure. So that I will devote the next 25 minutes to this topic about surgery of glaucoma in modern corneal graft procedures and conversion, okay? So first, you have to remember that glaucoma is a major reason of visual loss in corneal transplant cases. It's a major risk for graft failure. As a matter of fact, it's the second leading cause of corneal graft failure, which is a very important issue, right? Glaucoma might be present before the corneal transplant. Remember that among the frequent comorbidities of corneal blindness is glaucoma indeed, or we can suffer this problem following the corneal graft in patients that were not affected by this problem before the surgery. And there are two major risk factors in the development of this complication following any type of corneal graft. Remember, any type of corneal graft. The first is no doubt the steroid treatment regime. The steroids are necessary in the post-op, and the steroids are the first reason of this complication to happen. And the second is the pre-existing glaucoma. These are the two risk factors associated to the development of this complication, and the ones that will affect and will take a lot of your time, dedication, and patient's vision following the surgery. Chronic or acute intraocular pressure elevation has a negative impact on the corneal endothelial function and can even lead to corneal endothelial cell loss. The frequency of the loss depends from 10 to 33% in acute episodes, and this is something that you have to remember, the interaction between the corneal endothelium and the negative impact of high pressure. The mechanism for elevation following keratoplasty are different, but because we have sometimes intraoperatively and postoperatively the collapse of the aretocorneal angle, the steroid-induced hypertension, the inflammation that happens in the post-op, iatrogenic injury to the angle during the surgery, something that is not that frequent in experienced surgeons, but might happen when you are dealing with complex cases following trauma, and you have important references in which you can base your opinion dealing with this topic. Some of them are relatively classic, but this topic has not changed that much in the recent years in general. Early diagnosis and management of the control of the glaucoma and high intraocular pressure in corneal transplant indeed is one of the issues that lead to less complication and better outcomes. Excuse me. And one of the major advantages is that we are now in a different era in corneal graft, which is selective laminar keratoplasty, in which the decrease of the glaucoma incidence is clear, even that is not eliminated, but indeed we are in a different environment, safer and less affected by this comorbidity in laminar grafts. We have to remember modern corneal surgery is less destructive than the previous one. We have less need of steroids, and finally we have less complications. Even with that, we have the evidence that after 10 years of post-op, the graft survival is 58% only in glaucoma cases. Normally, it is 80% in patients without glaucoma 10 years. So you see that the sharp decrease in the expectations of the patient in which glaucoma is happening decreases about 50% of the chances to have a successful outcome after 10 years. Modern corneal graft has to be started in a different way. We have penetrating keratoplasty and glaucoma. We shall make this approach immediately. Then we have laminar procedures and glaucoma, and they are different in anterior laminar graft, than in posterior laminar graft, and in the MEC. And finally, we shall have at the end of this presentation about glaucoma surgery procedures in corneal grafted eyes in order to orientate your opinion and your selection for this procedure later on. Glaucoma following penetrating keratoplasty has one of the major incidents. It is reported, depending on the literature, from 10 to 53% of the cases. You have here important references about the frequency of this complication. The protective risk factors are listed here, from young patient age to pseudophakia, perforated corneal ulcer, floppy iris, trauma, pre-existing glaucoma, definitely, and previous anterior semestry. All of them are risk factors identified by and verified in the literature. So it is important to identify the risk factors proactively by the slit lamp, gonioscopy, and today is a very important tool, anterior seminosity, which in my hands has replaced totally, let me tell you, totally gonioscopy, because it's better to and more complete to perform. You have a much better perception of what is happening to the eye, and find that you have to get a printed, a firm registry to compare how is the evolution of the patient post-op. Other risk factors are indeed important, and they are happening during the surgery. Intraoperative changes in the iridocorneal angle with distortion and collapse of the trabecular meshwork can affect the outcome in the post-op. And this can be due to tight sutures, frequently, especially in the learning curve for corneal graft, undersized graft. When you use larger trifine shunt, and the larger it is, the worse, when you have a trauma to the iridocorneal angle because reasons related, for instance, to synechiae that you have to perform during the surgery, and also you use too much viscoelastic, or you have vitreous prolapse into the angle. It is for these reasons that traditionally it is advised to oversize the donor concerning the recipient of 0.5 millimeters, something that is not that necessary if you use femtosecond laser, because in these cases the adjustment of the donor to recipient is much more perfect, especially if you use modern profiles for the trephination. Postoperative risk factors are indeed, number one, inflammation, but number two is the appearance of synechiae, like those in the image. This synechiae can happen because reasons related to the immediate post-op or to issues that have happened during the surgery. You have steroid-induced glaucoma as the main reason for postoperative risk, and it has been demonstrated that you eliminate these steroids and you substitute by calcineurin inhibitors like cyclosporine or tacrolimus. You usually make the intraocular pressure to return to normal levels after 4 weeks, in which the corticosteroid has been discontinued. So it is wise to use steroid at the beginning, associated to these calcineurin inhibitors, and then to cancel the steroids after 1 month in cases that you have ocular hypertension, or to leave them but in a lower dose if you don't have this problem. There is an average of IOP reduction of almost 9 millimeters following this switch from corticosteroid to cyclosporine at 0.5%, which is one important piece of information that you get is the one coming from high resolution anterior OCT, in which you can see what happens during the post-op, not only during the pre-op, but in the post-op as well, anterior chamber angular abnormalities, the depth, the anatomy, how is the iris or not related to the involving the corneal wound, and many factors that really can make to you to decide to take the patient back to the operating room to restore normal anatomy. Let me show to you this case that illustrates how important is the OCT in this diagnosis. For instance, this is a 64-year-old male who underwent pediatric keratoplasty because suffered corneal decompensation with a lot of corneal scarring in the stroma following cataract surgery. The intraocular pressure was elevated following this procedure, and the anterior luminosity in this case, you see that shows well how is the graph, but tell us about the angle that is basically open. These cases are positive for topical medication, and cases when you don't have any anatomical problem, better are announced, or you have to consider that they are good candidates for topical medical treatment. You have to think that the medication, the molecule that is more effective following corneal graft are prostaglandins, followed by beta blockers, and so one of the main medications prescribed is associated with prostaglandins as beta blockers that sometimes are indicated in early cases in which the intraocular pressure is increasing. The third block is alpha-adrenergic agonists, which have the inconvenience of tolerance and irritation, and they are with a problems of toxicity for the ocular surface. And topical carbonic anhydrase inhibitors are indeed the less powerful. Indeed, steroid replacement by cyclosporine A or tacrolimus is associated to the use of this medication, trying to rule out and to eliminate the role of corticosteroids in this high intraocular pressure. And remember that if you use a anti-glaucoma medication, you have to use preservative-free drops because this is going to happen to be very negative for the ocular surface and especially for the grafted cornea. Surgical options indeed have to be considered when you don't have adequate response to topical medication, and you have complications of topical therapy, and the main one are the complications related to the toxicity of the medication. So the medication is one risk factor indeed in itself in the failure of corneal graft, and you have to take care how to use it. But on all these issues, you have one problem on top, which is the headache that it gives to the surgeon, the lack of reliability of intraocular pressure measurements after pendicular keratoplasty. When you use a Goldman tonometry, many times you have a distorted aspect of the ocular surface. The measurement of the pressure is imprecise. It's very much related to the subjective observation of the examiner, and this is why other methods that are based in the use, for example, of the eye care or other methods are becoming interested in these cases, but all of them in corneal graft are not reliable because the mechanics of the cornea have been so much changed by the graft that these methods like the tonopen or the eye care are not reliable, and they offer very frequently underestimations of the pressure. Remember, underestimation of the pressure is frequent. Use Goldman tonometry, but Goldman tonometry many times is not possible or is not reliable, and you have to end in using just your fingers to check if the pressure is high, something that obviously is not adequate or scientific. So corneal irregularity, graft edema, graft epithelium, if absent, all of them are major inconveniences for the measurement of the intraocular pressure in the post-op of these cases. And then you have surgical options, and surgical options when used in case of penetrating graft especially are one more problem. Look here to this 60-year-old female patient that had bullous keratopathy. She was with anti-glaucoma therapy, but not controlled with 3 molecules, and she eventually required the subsequent implants of an Ahmed valve in order to control the very high pressure. You can see here in the image the tube. The tube is not in contact with the endothelium, actually, is about 1.2 millimeters apart from the corneal endothelium. But in spite of this, 3 years later, the graft failed, and not because immunological radiation, was because of the graft. So grafts and valves are not the best friends, and you have to consider that these surgical options, we shall go through this later on, are options that are very good for the glaucoma control, not that good for the cornea. The reported graft survival in these with different kinds of glaucoma filtering devices is 58% only, and 92% are 1 year after penetrating keratoplasty, and falls to 25.8% to 70% at 2-3 years. So following penetrating keratoplasty, you have a very negative impact of any glaucoma valve, decreasing, as you see, from 50 to 1/4 the chances of the graft to survive. This has been confirmed by many authors, and indeed this happens even with only with one surgery, and in cases in which surgery has been performed before the corneal graft. Look at this data from Hollander, in which after 1 year, they started reported graft survival following one particular type, the Ahmed valve or glaucoma filtering procedure, was 57.7% at 1 year, which is not a good number, but was 42.9% at 2 years, and only 41% at 3 years. So look how this surgery, even if properly performed, has a very negative impact on the outcome. So we have risk, and the risk is because of the valve. There is no consensus about why the valves are influencing so negatively the prognosis of the graft. But one is that the irritation and trauma created by the tube. You have to trim the glaucoma device tube properly at the moment of the pendicular keratoplasty, or when you are using it, in order to keep it as far away to the corneal endothelium as possible. But you have to consider that the escalation of the glaucoma therapy might be needed after PKP, as intraocular pressure is very important to control. So first try medical therapy, use a valve, but the valves for any reason are associated to the problems. Fail is frequent, and fail is not only traumatic because of the tube. You have cases as the one I mentioned to you that without any apparent reason, and this is very speculative, you have other factors involved that involve the prognosis of the corneal graft when you use valves preoperatively of after the surgery, as it has been documented in the literature. Following lamellar corneal surgery, you have a different scenario because in the DMEK and the SAIC, you have the stroma intact, and in DALK, you have the endothelium intact. Glaucoma after DMEK is no doubt the most serious complication, and in this very successful surgery, DMEK is indeed bringing problems to you when you have glaucoma and you have to decide what to do. There has been several papers recently about the frequency of this problem, and after 12 months, the incidence of IOP elevation chronic requiring medication is going from 6.5 to 11.1%, which is the data that has been more recently reported. The biogenesis in early cases is related to the surgery. In the DMEK, you use, as in this side, intraocular gas, and you have air bubble-induced mechanisms that happen to take action during the surgery. But after the surgery, you might have persistent inflammation, peripheral anterior synechiae that can be induced by the surgery because of this collapse of the iris onto the corneal endothelium. There's a membrane adhesions that come because of this problem as well, and the surgery response, which indeed is again one of the main reasons related to the problem. The reported new glaucoma rates following DMEK go from 2.8 to 6.5. So as you see, we have a problem in DMEK with glaucoma that affects broadly from 5 to 9% of the patients in general. This has been documented recently, and indeed is one of the problems of DMEK. How to make in DMEK any prophylaxis of this problem? We always prefer this before the DMEK, and you have to planify before doing the DMEK to make an inferior peripheral laser iridotomy. If the cornea is not adequate for the purpose, then you have to do it, as most of the times is needed, during the surgery with a vitrectomy probe. The air bubble has to be made with a volume of less than 80% of the air chamber volume, and you have to take care that the bubble is not going behind the iris, not to induce the appearance of synechiae. You have to use steroids that are weaker as far as we have lower risk of rejection following the DMEK, and fluorometholone is acceptable, especially after the early post-op of 3 months. And these are the two references that I would like you to remember about this problem. For pupillary block by air bubble, we have to remember that pupil dilatation during after the surgery is important. You have to use acetazolamide orally during the first 2 days, and you have to make the patient to be consistently in the supine position to 1 to 2 hours for the bubble not to go behind the pupil and to create the problem. If the pressure, in spite of this problem, is high, you have to remove the air, and you have to monitor these cases of DMEK for the first 2 or 3 hours to avoid this high acute increase that is related to the gas that we inject in these cases. Glaucoma has to be considered in these cases as a potential indication for surgery, and you have to be very careful with all the devices that can affect the anatomy of the segment, especially grafts, especially valves, because they can affect negatively the prognosis of the graft. After the SAIC, the problem is about the same as DMEK. The SAIC is only different from DMEK because of the remaining stroma that is left in order to make surgery easier. This increases a little bit more the corneal thickness, but it's not modern surgery that relevant. But you have to think that the complications of the DMEK and the SAIC are recovering. They are related, most of the cases, to steroid use and to the use of gas during the surgery. The management is the same, and as the most frequently performed in the DMEK and the SAIC procedure is trabeculectomy, which has been reported to be successful in these cases as well, and you have this reference to quote in this case. After the anterior keratoplasty, we have one advantage, that there is no distortion of the angle at all. You are not penetrating the anterior chamber, and this is of glaucoma is not expected to be related to anatomical problems. This of glaucoma, anyhow, exists because of the steroid use and has been reported in similar levels than the DMEK and the SAIC, with from 4.48 to 17% at 5 years, according to references that I'm quoting here, and the topical steroid use is the reason for that. The management in DALK is the same, to eliminate or to decrease the use of topical steroids, and you might need a surgical procedure in order to control, in these cases, the high pressure when the topical medication is not effective or is toxic and is not creating a positive response in the patient. Glaucoma after DALK is the case of this example that I'm putting and I'm indicating to you. The patient of mine, of 70 years old, that was implanted with a had this surgery, a DALK, then suffered trabeculectomy related to steroid responsiveness. Then, because this failed, was taken with an express valve, and express valve was successful after 3 years, which is the follow-up that we have in this case. So trabeculectomy fails more frequently because additions and because problems related to the anatomy related that is involved in trabeculectomy than microglaucoma valves of stents like the express valve. Anterior keratoplasty can be performed following glaucoma surgery. The answer is yes. You have a filtering device, but this filtering device is not making you to ignore the use of DMEK on these cases. Basically, the valves are not, especially the trabeculectomy and the microvalves are tolerant with these cases, and you can use even gas with acceptable results and with no major problems. Anterior semen is usually abnormal anyway in many cases when glaucoma surgery has been performed. And if you have this problem, you have to solve the problem of the anatomy before implanting the valve. And remember, in these cases, whatever valve that you implant, especially you are using the Ahmed valve or similar, you increase the risk of corneal graft failure. And corneal graft failure following DSEK with these devices has been reported to go from 18 to 75%, which is indeed huge number. DMEK after glaucoma surgery, as I told you, is possible. This is a case that we have published in Cornea of a 44-year-old female that developed glaucoma following the implantation of artificial iris. This awful surgery that is performed still today in some places. And this eventually required, after 2 years, the implantation of artificial iris, and later on the use of an express valve P200 for persistent elevated intraocular pressure. Here in the image, you have the gas following the DMEK. This express valve was there, and even with not a high volume of the gas, the DMEK was extremely successful, and the patient had a total resolution of the edema and was controlled properly, and is controlled still now after 3 years of follow-up. Some additional procedures and preventions have to be taken if you are using DMEK in a case in which you have been already performing a corneal glaucoma surgery. You have to be aware and look with the anterior semenosity how is the anterior chamber, and to perform analysis of the iridocorneal adhesions before the DMEK. If you do it at the moment of the DMEK, you will generate fibrin, and this fibrin will make a hole in the post-op and will make the patient to fail. You are using an Ahmed valve similar. You have to train the tube shunt before the surgery to make room for it, and much better is to take the shunt behind the iris or to the vitreous. The corneal incision should be more corneal rather than limbal, not to preserve the pre-existing filter and bleb in case that you have trabeculectomy, and you have to fill completely with air the anterior chamber better than with gas, and then later on you can substitute the air by gas in case that the elimination of gas is too fast for the purpose of the case. Refilling if necessary should be done with gas 20%, and this is my approach to this case. What type of glaucoma surgical techniques can be performed in corneal grafts? As we know and has been reviewed in this part of the presentation, glaucoma is a serious and feared condition in corneal transplant cases. The control of the intraocular pressure is mandatory for the survival of the corneal graft and, of course, of the vision of the patient. And glaucoma surgery is frequently necessary to control adequately intraocular pressure because medical treatment is not always successful. So what glaucoma procedures we have? Obviously, we have trabeculectomy, glaucoma drainage devices, the express mini glaucoma shunt, deep sclerectomy, cyclocoagulation, and all of the trabeculectomy is still the procedure that is a gold standard in the management of glaucoma, even in corneal grafts. It is one of the most widely used procedures and probably is the first to be performed in the opinion of many corneal surgeons. But you have to take some preventions when doing penetrative keratoplasty, especially if the patient has been operated before the surgery. As far as you have to pay attention to the conjunctival bleb, actually part of the trephination can be affected in its quality because of the pressures of the bleb, and suction ring cannot be adapted adequately. And you have to be sure that you eliminate all the OVD after the surgery in order to prevent the obstruction of the filtering procedure that happened to be in the product. However, trabeculectomy is not the preferred practice of many surgeons, including myself. I don't perform trabeculectomy in corneal graft cases. I prefer to use other procedures. The reason is that you have to use mitomycin C. Mitomycin C is toxic for the cornea and is toxic for the wound healing of the cornea, and this is why I don't use it. Even in perfectly performed cases, the rate of corneal failure for failure for trabeculectomy following PKP is 37%. So you have a relatively poor prognosis of the trabeculectomy in PKP cases for reasons related to the natural condition of the anatomy. Trabeculectomy alone is less effective in glaucoma following anterior keratoplasty, and blade failure is frequent, and because conjunctival inflammation is more frequent as well, and the scarring that happens consequently. This is why glaucoma filtering devices, glaucoma draining devices are frequently used. They are, in my hands, the favorite to use, and I like, and many of us like as well, the Ahmed glaucoma valve and all other non-valve like Molteno and Baerveldt. The outcomes are equivalent in all of them. The success rate in controlling IOP is higher with these devices than with any other, but the problem is that you have an associated high endothelial cell loss, and the graft survival definitely is compromised by this. This is why I recommend these cases to implant the tube in the vitreous cavity or in the posterior chamber in cases of pseudoephychia, because this will create an anatomical barrier and a limitation of the damage of the tube to the endothelium, which is not only related to the physical touch, but probably related to the fluid dynamics and anterior chamber that are very much changed with the pressure of the tube. The success rate of glaucoma devices is about 80%, which is indeed higher than in trabeculectomy. Indeed, the outcomes are better than trabeculectomy, and this is a consistent agreement among others in this regard. And in cases of the MEC, the outcomes are identically good, and you have to remember that the tube should be placed, if possible, behind the iris in any way in order to prevent the damage of the endothelium in the postop. Glaucoma surgery, remember, increased the failure rates of keratoplasty of all types. Stewart reported that 3 years survival following PKP is 72% in eyes for glaucoma and 86% eyes without glaucoma, and 63% only in eyes with previous glaucoma surgery, which really makes glaucoma surgery a very negative risk factor for the survival of the graft. The long-term survival of anterior keratoplasty in eyes with glaucoma filtering devices is not good, and at 1 year the incidence of graft failure ranges, different authors mentioned, from 8 to 51%, which is a major loss. This is why other valves are to be considered. The mini shunts, like the experts, have a role in this case, especially when you use laminar grafts. They are minimally invasive. They are far less invasive than the glaucoma filtering devices like the Ahmed and the others. And the studies have confirmed its efficacy and safety, because this topic has been controversial in the different types of keratoplasty, but especially in laminar procedures. There's a recent paper published by a Spanish group about this topic, and indeed, this has a role in well-selected cases indeed. There are case reporting which will have 48 patients with keratoplasty following the compensation that happened in endothelium because of fake intraocular lens. The patient, as you can see here, had extensive synechiae, and following bilancectomy, the patient was left with a 270 degrees adherence of the areas to the peripheral cornea. In these conditions, obviously, nothing can work, and this was operated with an express valve implanted in the posterior chamber, so behind the iris, and 7 years later, the patient was again with a pressure elevated. So all these procedures are affected negatively by time, but in the case of the arm of this valve, it is very easy to re-explore and re-examining the area of the surgery and liberating the fibrosis and making the filtration to be again active. This was successful, and the patient was managed in this way years after in a surgery. So express valve is effective in the immediate post-op, it's effective in the medium post-op, and in case of failure, can be revised, and this revision leads to a positive filtration again in many cases. So this is one of the valves that we use, and we believe that is an adequate one, and is less traumatic than the Ahmed valve and similar. Non-penetrating deep sclerectomy, which is very popular in some European countries, for instance, Spain and France, It's a good option as well because it doesn't affect the anatomy of the chapter. The problem is that 6 months you need a goniolysis, and this goniolysis is creating the long-term good control of the pressure, which is affected by the appearance of this fibrosis of the descending membrane. The success rate is 66% and 45% at 1 and 5 years. So that means that they are less effective than the valves, even that they are effective and they are less invasive. The long-term survival is better after non-penetrating deep sclerectomy than in trabeculectomy, and about the same that happens to be with the express valve. It's safer in the MEC cases, and it's a choice that you have to consider in cases of laminar graft procedure. There's a controversial opinion about cyclodestructive procedures. The control of the pressure by decreasing the aqueous humor production, destroying part of the cellular body, is traumatic but is effective. It happens with cyclotherapy, neodymium jar laser cyclophotocoagulation, down laser cyclophotocoagulation, transpupillary argon laser photocoagulation. But the problem is, are the controls of the intraocular pressure good? If you go to the literature, you can find positive and negative opinions, and this topic is controversial. What I can tell you, and this is my own experience, there are many complications following this procedure. You have hypotony, persistent inflammation, macular edema, corneal decompensation, choroidal and retinal detachment can happen even that they are rare. Sympathetic ophthalmitis potentially possible, very rare as well, and this is worldwide. Diode laser treatment associated with a lower incidence of complications, and this is probably related to the highly selective destruction of cellular body epithelium. So it's true that it's effective. It is true that happens to be controlled. Most of the times you need more than one procedure, but the problem is that you don't control the outcome. This is one case that makes to you an example about which is what you should expect from these cases. This is a 56 years old diabetic male that developed refractive glaucoma following pendular graft. You see here in the RCT that there's a total adherence of the iris to the back of the cornea, and this extension of synechiae make it totally impossible to control by any other method than the treatment. Patient refused surgery and was treated with cyclocoagulation, and indeed the following this procedure, the pressure was controlled, but visual loss was observed. And this is the problem. These cases following one or two cyclodestructive procedures can, in a non-reversible way, to lose vision related to macular edema and complications related to the inflammation. So we dislike very much these procedures, and we try not to use them. We use them only in blind eyes or eyes in which there is no useful vision already. One study reported the outcomes of cyclophotocoagulation for glaucoma with a failure rate of only 20.7%, which is about what is offered by the glaucoma valves like the Ahmed. So there is no advantage in using cyclocoagulation other than it's more comfortable and less expensive. Other recent study in which they use micropulse and sclera cyclophotocoagulation in 61 keratoplasty eyes, only 10% needed subsequent filtration, and its regression survival was 94% at 1 year, and 81% at 2 years after the laser treatment. So probably you need to use these cyclodestructive procedures. The micropulse and sclera cyclocoagulation should be probably the only one to use as far as the outcomes reported are quite favorable in this case. So just from following this complex topic lecture, I would like to give you some take-home messages. First, remember that we are dealing in any case of keratoplasty and you have a high pressure, you have to fight in 3 different arenas. One is in the control of the pressure, but you have to control the pressure in a way that the graft survives. And finally, both have to be done in order to the patient to have vision. This is the balance is what will make the patient to be successfully treated. You use a procedure that will affect the vision, controlling the pressure and affecting the graft survival. This is obviously not adequate. And if you are looking only for the graft survival and you lose finally the vision of the patient because high intraocular pressure, you don't make for the patient any favor. So you have to identify the risk factors to allow no more adequate follow-up and early management of the glaucoma in the most convenient way. The knowledge about adequate management of glaucoma that either that has been developed and present before or is more frequently after keratoplasty may save many eyes from non-reversible damage of the optic nerve and indeed can increase the graft survival. Just to remember to you that we have this course that part of the junior staff and residents of your institution are following. Clinical method refractive cataract corneal surgery were ready to start in 2 months. the second cycle, the second edition, the second generation of this course. We invite all of you to remember that this course is available for you for topics related to this area, refractive cataract and corneal surgery. Thank you very much for your kind attention, and it's a privilege. I'm very happy that we could connect today with King Khaled from Spain in this moment with the COVID-19 is giving so much trouble to the world. So thank you very much. Keep safe, and of course, I will be happy to have any question from your side, Edmund. Thank you very much.
Thank you, Jorge, for such an interesting lecture. Definitely, glaucoma is something that we are all used to do, but it's not a surgery that is free of complication. Definitely, glaucoma is one of the worst scenarios that we can face. I strongly recommend, I always tell my fellows, please try to identify the risk factors for glaucoma on these patients, because this will make a big difference in the future of this corneal graft. So if you can see, Jorge, in the Q&A panel, you will see some different questions. The questions that are already addressed directly to you, please respond as many as you can.
Yeah, okay, let me go just by the number, that they have been made by me. First question, how do you deal with a 360 degrees recurrent anterior synechiae and a PKP? My friend, you have recurrent synechiae, no way to treat it, no way, because whatever you do, there is a memory, and the memory is because of the fibrin and the retraction of the iris that will make the synechialysis to be not successful. In this case, you have to abandon this possibility to replace the iris, and then you have to make available a valve behind the iris, which is the only one option. And in these very cases, I'm happy to use the Ahmed valve, because in this case you have already the peripheral cornea protected by the iris, and in these cases you have to be directing the tube slightly deep towards the lens. In this case are pseudophakic, and a second option is to do it in the vitreous, which is a good option as well. There is no other option, and you will see in the OCT at 270 or more synechiae, you have to go for surgery, better early than late. Other question about cyclocoagulation instead valves. I am not a good friend of cyclodestructive procedures. I have to tell you that I don't like them because several reasons. First, I don't control the effect. Second, they decrease the vision of the patient. We know that for the different mechanisms. Number three, they are destructive for an essential part of the eye, which is the ciliary body, and create inflammation, which is indeed one of the risk factors for coronary rejection. And finally, they are not surgical. They are very, very rough and very unelegant. My advice is to use valve always, and I use only cyclocoagulation in cases where the patient is blind or almost blind, and we look just to keep the eye, but not to save the vision at all. About what treatment I prefer in order to use steroid as little as possible. My normal regime is to use one drop every 2 hours for the first month, every 2 hours respecting the night of the patient. And then following this, depending on the pressure, because after 1 month, if you are going to have an steroid response, you do know. If we don't have any problem, then we continue every 2 hours, even for a couple of months. But from the very beginning, after 2 weeks, we start topical tacrolimus 0.3% ointment once a day. This is very important because in case that you have to decrease the use of steroids, you can decrease it, but you already have the tacrolimus, better than cyclosporine A, my hands, protecting all the rejection T-cell mediated response to the cornea. If you have finally to eliminate steroids because it's a response, you can do that only when you have planified the surgery, because you can eliminate the steroids for a while, but you have a high risk of rejection if you eliminate and you live without the steroids this pain. So for me, steroid responding patients are switched to use of tacrolimus, 0.3% better than the cyclosporine, and immediately we think in the surgery without the patient listen, if this is not going to be controlled with low treatment regime steroid, surgery is indicated, and we do it early. The earlier the better, because the later is more toxicity of topical medication and probably less potential remission for the patient. About micropulse laser, I have not direct experience of it because I have been observing this technique, but I don't use it. So what I can tell you is about what is written in the literature. The literature with micropulse laser is positive. So I am happy to try to use it. But again, as it is a cyclo, this destructive procedure, due to the lack of control, could never be my favorite. I prefer to use valves. My initial approach depends on the anatomy. If the anatomy is good, imagine that you have lamellar keratoplasty, gaze normal anterior chamber, short response, high pressure. Glaucoma valve, for me, my favorite is the express. If you have a problem with the iris, with synechiae, then I prefer the Ahmed valve. In general, better to use Ahmed valves than express valve. Express valve is less invasive, less traumatic, is in all aspects better for the patient, but is less effective in the control, even that can be repeated and can be restored. So I use it, but I have to tell you, valves type Ahmed have a better role in these cases, even that the others have as well in selective cases. And my experience with a trabeculectomy is bad. Corneal graft is not a good friend of trabeculectomy. I think that the anatomy of the anterior chamber, when it's penetrated by you in trabeculectomy with a narrow anterior chamber, etc., involves the development of synechiae. As you know, express valve is not better in terms of outcomes than trabeculectomy, but it's better in terms of complications. So I prefer to have less complications than trabeculectomy, is why I use express valve. Let's say that in my cases of surgery following corneal graft, about 60% are treated with Ahmed valve or similar, and about 40 are treated by express valve. And no one is operated by me with trabeculectomy. I use mitomycin C always, and you have to be sure that when you do this, so that this is not to be the last surgery of the patient. Rather than that, if you use valves, you will need to explore the valves to activate them and to be sure that you have an adequate monitoring control on the outcome of the patient of these valves, because many of them become not active with time, and sometimes it's early post-op. About what is the window, this is another question, between corneal graft and tube or ciliary photocoagulation and vice versa. The window is depending on the case. If you have a patient with an acute increase and you have in the 40s and the pressure is not decreased by medication and you have to cancel the choice, surgery can be decided after 2 months. If you have this modest but evident increase in the 30s, you have 2 molecules, 3 molecules, the patient is resisting, the cornea is thick, you don't know if you are measuring the right pressure, you can delay, but you know you have really a pressure that is out from the control over 30 millimeters of mercury with 3 molecules, the case is for surgery. And these cases, if the anatomy of the angle is good, I prefer the express valve, and the anatomy of the angle is not good, I prefer the Ahmed valve. I think that they are most of the questions. No, we have more. Okay, a deep sclerectomy is better than conventional trap? The answer is absolutely yes. I like this technique. I don't use it that frequently because I have many patients from abroad, and some of them cannot come after 6 months for the goniolysis. The goniolysis is mandatory after 6 months in deep sclerectomy. This is why I don't use it that much, but you know, you don't affect the anatomy of the anterior chamber, you don't have synechiae, you don't penetrate the eye. It's indeed a good option, and I like it in cases with no commitment, anatomical commitment to your chamber. Question.
Jorge, ¿me escuchas?
Dance, yes, yeah,
Sí.
listen to you.
Sí, I asked that question.
Okay.
Yeah.
Good.
So I'm curious. As an outside observer of this, the logic of deep sclerectomy and the advantages of deep sclerectomy. I understand the technical difficulty of the surgery itself, and it can take longer than doing just a trabeculectomy. But in terms of what's better for the patient, what I don't understand is why glaucoma specialists aren't all training in this procedure and making that the procedure of choice, when possible, obviously, because as you say, the risk of inducing cataract is almost zero. The need to do a goniotomy perforation is not 100% in these cases. And so, and anyway, anybody can do that procedure. Even if they don't travel back to you, they could still do it back home. Anybody can put a lens on and punch a hole in the trabecular meshwork. You know, why is it that this procedure, or is it just a question of time before this happens?
You know, Dan, I like the procedure. I think that you listen to me, that I like it a lot. I think it's a fantastic procedure in cases that you have a normal anterior chamber, so you have no synechiae, but you have to get the post-op of this patient in 6 months, because after 6 months, all deep sclerectomy requires goniolysis.
No. All of them?
All of them, all. If not, the success rate decreases to 40%. I know.
Are you using a spacer
This is one of my favorite procedures, so I know, you know.
Okay.
So as my patients, many of them are not from Alicante, and I will not see them after 6 months. I don't want to get them into trouble because nobody would do goniolysis, you know, once that this happens. And the success rate in my hands of deep sclerectomy is about 85%, which is good. You know?
Very good.
But after 6 months, it's 40% and recovers to almost 80% with goniolysis. But if I have the chance to see the patient myself, if the patient has a good conjunctiva, you know, and it's a patient I would see in 6 months, I prefer deep sclerectomy to valve, clearly, as far as the anatomy and the chamber is good. So I totally agree with you. The opportunities that you have depends on the availability of the patient.
Great.
Thank you for the question. Thank you very much. So I have
learning from you.
There are other interesting questions here. Yeah, one is in Spanish. Do I perform, is Dr. Jesus Ramon Alvarez Felix, a routine procedure for glaucoma in the neck and mini express in vitro, mini express valve cannot be in the vitreous, can be in the posterior chamber, never in the vitreous. Ahmed valve can be in the vitreous. If you have to perform some anterior chamber vitrectomy, if you do that, because you need the vitreous either to be liquefied or you need the vitreous to be excised, obviously. And my procedure of choice, as I told you, depends on the anatomy of the anterior chamber and the severity of the glaucoma. If you want to be in the safe area, the most effective is clearly the Ahmed valve, Baerveldt or Molteno. You know, these valves are the most effective. You want to be conservative, you can be with express, which works well in selected cases. You want to be a good surgeon in good selected cases, deep sclerectomy is fantastic. I don't like only, as I told you, trabeculectomy. Okay. About to identify proprietary responders is good. You know, many of these patients, they suffer glaucoma, excuse me, corneal blindness, and they use steroids before surgery, and you identify them before. You remember that at the beginning of the talk, I explained to you that one of the risk factors for graft failure is pre-existing glaucoma, and you obviously have this in all cases in which you have used steroids, you detect the steroid response. Yes, they have to be considered as glaucoma patients from the beginning. And okay, about other questions. Okay, metabolites, the use of metabolites always. You know, you are dealing with risky cases. High risk cases of failure is both for valves of any type, trabeculectomy and non-penetrating. Not only you have to use mitomycin. Mitomycin, as you know, has corneal toxicity and can reduce the healing rate in the area of the sector in which the mitomycin has been used. It's one of the reasons to use the valves as well. Ahmed valves and the others do not need anti-metabolites, or at least I don't use them when I decide to use them in my patients. About the use of acetazolamide in the pre or post-op, I do. In the early post-op, I use acetazolamide in all my cases. Why? Because I never saw that I had removed all the viscoelastic. And if you have viscoelastic, it's awful to have in the next day 50 millimeters of mercury in the eye like a rock, because the viscoelastic has then to be removed. This is extra trauma, but especially because these high spikes of pressure creates inflammation and are risk factors for endothelial failure, and of course, that exposes the patients to a bad postoperative and not only to early spike failure. And about failure in the express valve, if I use express valve, is acceptable because I consider that has an indication. If it fails, then it depends on the case. With OCT, you can see you have fibrosis of the filtration area. You have fibrosis, then you can operate and you can excise the fibrosis and the valve is working again. You can even substitute the valve. If you have a normal anatomy with no synechiae, you can explore the express valve, leaving the same one or changing it. But if you have the anatomy distorted, it's better to change the valve, the express, by a Ahmed valve, which is my choice in this case. Good. And about when, this is a good question, when to measure the pressure in these spaces. You know, I told you one of the problems, you cannot measure the pressure many times because the government doesn't give to you an accurate measurement. You have regular cornea. Many times you don't have it in epithelium, so you don't have an adequate environment in which the pressure is properly measured. You have to use, and I use it, but I have to tell you, not happy to use the eye care. Eye care, as you know, is rebound tonometry. It's very safe because you touch marginally the cornea, you throw it away, so contamination is almost impossible. But the problem is not reliable. The different hysteresis that you have in the donor tissue and the recipient makes usually to underestimate. Remember, underestimate the pressure. You don't overestimate, you underestimate the pressure. Air pump devices usually overestimate the pressure. So with a rebound tonometry, you underestimate. With a air pump, you overestimate. What to do? Your fingers can tell you if the eye is hard. It's not elegant, but at least can give to you, if you have experience, how is the eye. But definitely you have to control the pressure in the first days. The earlier the better, and I do it from the very first day of post-op, usually with the eye care. Eye care is the one that I use. I don't like to put drops and to touch the eye. If the patient has a contact lens, I leave the contact lens and I measure the pressure. With the contact lens, you increase the measurement about 1 to 2 points, so it's marginal, it's not important. But really, you know you're dealing with a high pressure or not. And finally, if you have any doubt, use your fingers and then use acetazolamide oral. Try to be thinking in the early post-op about the pressure of viscoelastic. If you have viscoelastic, remove it. Take the operating room, you have paracentesis, you have to remove it. And if it is a late problem, you have to talk to the patient. My friend, you are going to have glaucoma surgery as soon as the inflammation is decreased and your eyes are adequate for the problem. So,
Jorge.
Yeah.
Professor Sathish have a couple of questions for you. Professor, you can talk. You are in mute. You can ask directly to Dr. L.Alio a couple of questions that I saw on your screen.
Sure. Hello, Jorge. Mucho gusto.
How are you?
I'm good, thank you. Nice to see you. Great lecture. What is your experience of the risk of glaucoma following lamellar keratoplasties? For the benefit of the audience, do you think it's more with steroid induced rather than pre-existing glaucoma? And what are your thoughts on glaucoma in lamellar keratoplasties? Because most of the glaucomas incidence is much higher in patients with PK compared with lamellar keratoplasties because of the anatomical alterations in the lamella.
Yeah. You know, Sathish, thank you. This is an important question. I almost answered already during the talk, but number one, if you have persistent glaucoma, this is a risk factor. Clear, you know, and then better deal with the glaucoma before the DMEK. Better do it, you know. And what I do glaucoma surgery. I do an express valve in these cases behind the iris. If the patient is pseudophakic, patient is not pseudophakic, then I have to decide to do the express valve and to make it in a way that the patient can have a DMEK after the surgery. DMEK is my choice. I don't use DSEK any longer, you know. And in DMEK cases, if you have high pressure in the post-op, you are in a much worse environment, because then you have to deal with a glaucoma in a recently implanted tissue that will resist less the surgery. So any glaucoma that is detected before DMEK, I do the glaucoma surgery before, and then 1 month later, I do the surgery. 1 month or earlier, it depends, you know. About the gas in the anterior chamber is amazing, is not eliminated by the valve. So this is my experience. If you have an express valve and you put gas in the DMEK, the gas will disappear 2-3 days after, but this is enough for the DMEK cases. You don't need more gas, more time, usually, you know. But the rest of the cases are steroid-induced. Steroid-induced can be reversible or non-reversible. You have steroid-induced glaucoma that responds well to the cancellation of the treatment of steroids, while others are not. About 20% are permanent. And these cases are, again, to be considered for surgery. The issue with steroid-induced glaucoma is that usually it is not in the low tens, or the patient is not 20-something, it's 30-something or more, and is consistently high. High pressure is negative for the corneal endothelium, and you have to control this. So in previous glaucoma cases, I solve the glaucoma and then do the DMEK. If the high pressure happens afterwards, then it's a steroid response. I try to control the steroids, calcineurin inhibitors. If not, glaucoma. And what is my technique? Ahmed valve. In these cases, because when you are dealing with DMEK, you are dealing with a normal or very good anterior chamber anatomy. These cases are good for the express valve, and I try not to use the Ahmed, not because I don't like it, that it's the most effective device. Remember, the problem is that it is the most traumatic, and the success rate after DMEK and glaucoma valve, Ahmed or any other similar, is decreasing about 40 to 50%, which is a dramatic decrease after 5 years.
Thank you.
I think, Jorge, we have time for one more question. There is one question here for Dr. Luis Lu from Arizona. It said that in pseudophakic patients with PKP and uncontrolled glaucoma, which procedure will you consider will have better prognosis for the IOP control and the PKP survival?
Okay, Luis, thank you for this question. Is one of my friends for many years, a person that I admire very much. So thank you for being there. But for me, it's a honor. I prefer the Ahmed valve. PKP is a different animal. If we're dealing with DMEK or DSEK or DALK, the anatomy of the anterior chamber is usually not distorted. But when you have penetrating graft, most of the cases you have in glaucoma some distorted anterior chamber. I prefer to use glaucoma Ahmed valve, but in the vitreous. If the patient is pseudophakic, I can decide to be in the posterior chamber, but most of the times I feel safer to put in the vitreous. It's guaranteed to me that this interaction that is mysterious is something that nobody can really tell you why. If you have a tube in the anterior chamber, which is in cases of normal graft, of normal patients, not creating corneal compensation, you have the compensation years after, even without a touch. But I think that there is a negative interaction with the corneal endothelium of the donor. In any case, Ahmed valve is my choice, either in the posterior chamber behind the iris, or my favorite is behind the lens, so the pseudophakic cases in the vitreous, with a controlled limited vitrectomy that I do at the moment of the surgery. By the way, I do the vitrectomy myself. So I manage these cases. Glaucoma, I manage myself. I do the graft, and I do the vitrectomy. So this is other probably tip that I want to tell you. You have to be, when doing with these cases, a comprehensive surgeon. I don't believe that multi-specialty practices are that successful, because you have to take decisions in the moment of the surgery that really makes it impossible to have three specialists, the glaucoma, the corneal surgery, and the retina in the same place. You have to know how to do a controlled vitrectomy. It's very, very simple. If you are going to make a valve in the vitreous, you have to do the glaucoma surgery yourself to protect the cornea. Being the corneal surgeon, be sure you will love the cornea much more than a glaucoma surgeon. And finally, you have to preserve the cornea for the vision of the patient. So all this should be done, in my opinion, by the same surgeon, which is you. You need to receive this education.
Well, thank you so much, Jorge. On behalf of King Khaled Hospital, the Global Education Forum, we want to thank you once again for being part of this program. We really appreciate your lecture, and we really appreciate your time for being with us. Thank you so much.
Thank you very much.
We will see you soon. Thank you.
Thank you. Ma'al salama.
You're welcome to stay for the next lecture, please.
Thank you.
Okay, thank you. So now we will start with our second lecture. Will be a symposium about premium solution for faked and pseudo-faked patients. For this, we have three guest speakers today. We have Alexandra Kontur. She's a medical, and she has a PhD in biochemistry. And she comes from the Charles University of Prague in Czech Republic. And she is very famous because she has a lot of publications about inflammatory eye disease. We have Dr. Joaquin Fernandez from Spain. He's an ophthalmologist and also has a PhD He is the founder and the medical director of Q Vision. And we also have the honor and the privilege to have Professor Sathish Srinivasn from the University Hospital Ayr and the University Hospital of Cross House in Scotland. Actually, he is the director of the iShare Clinic. All of you, welcome. And we have a program for today. We will start with Alexandra. Alexandra, can you hear me?
Yes, I can hear you. Can you hear me?
Yes, we can hear you and we can see you as well.
Okay, so I will share now my...
Yes, on behalf of King Kali Hospital, we want to welcome all you guys for this symposium. Now it's time for Alexandra. She will be giving the first lecture, which will be titled The Science Behind Multifocal IOLs. Welcome, Alexandra.
Thank you very much. Hello, everybody. Good afternoon or good before noon, whenever word you are momentarily. I would like to greet you from Budapest, Hungary. And I really thank for this opportunity to join this symposium. I will share now my screen.
Okay, now we can see your screen.
Okay. I just have to, just a second. Okay, so can you see everything? Okay, so this is my disclosure. I am, yes, I'm ophthalmology. I am an ophthalmologist. I used to work as a specialist for inflammatory eye diseases, but since over 10 years now, I'm just scientific director at the Kontur Medical Engineering. And this is co-authors or just co-operators of the little bit overlook what is behind presbyopia correcting IOLs from the little bit dive from the company point of sight to just know a little bit more about different technologies, because I think it's very important for you during the practice when you are choosing IOL. So each company would like to design perfect multifocal IOL. What everybody know today, this is not the case, that multifocal or presbyopia correcting IOLs are still kind of compromised. But despite the fact that there is something like 5 to 7% on the market shares, there is a big demand from the patients and the market share is growing because also technologies are improving, and of course also experiences doctors who are implanting in every day are just getting better and better. So when there is a multifocal lens design, there are different factors. These are engineering designing factors. So we have to look of energy distribution, and I have to tell you that each company, each producer working with the same amount of energy. We have to take into consideration pupil, and optical surface, high tech and precision is extremely important when developing and producing multifocal IOLs. And material and design, last but not least, because sometimes it's just forgotten, but if you want to have a premium technology, we should also pay attention of premium material and design. And of course, then there is a patient side, the light condition, environment when he or she is working, how his or her pupil is reacting to different, reacting, and what kind of profession patient has on eye status of the patients. You know, today's kind of boom of different technologies of presbyopia correcting IOL, I didn't include accommodative because they are not on the focus today too much, but the start was with refractive, either concentric zones or asymmetrically segmented. There are still some of them on the market, but the big movement is direction to diffractive IOLs. And of course, they started with bifocal. In 2010, there was a big breakthrough with trifocal and improvement of the quality of vision and life of patient with the first trifocal lens, but then many others came to the market. And then, as you know, the big fashion today are edge-off lenses. This is the question if it's really, it's bring something new from technological point of sight. I can tell you that they are rather going back because they are, at least those two are from the diffractive point of view, they are just simple bifocal lenses. And there are new add-on coming to the market, other technologies at diffractive and also part of refractive. But I would like to focus today on diffractive and mainly trifocal IOLs. You see there are different main technologies or main competitors today on the market, and at the first glance what you can see that each company presents you some technology, and here you can see on the screen like a small jacks or steps, and let's see what is behind this. But if you want to know what is behind this, we should a little bit go and dive into the diffraction. What is the technology behind the diffractive lens? So diffraction refers to various phenomena which occurs when bending of waves around small obstacle or slit, and then the spreading out of waves past small opening. And when it happens, the constructive and destructive interferences occur. So here you have a wavefront, there is a slit, and immediately after wavefront, after the slit, wavefront just change the wave shape, and constructive and destructive interferences occurs. And when developing intraocular lens, usually companies try to utilize these constructive interferences as much as possible. Here you see a little bit from more physics. So here is the wavefront. This distance in between is wavelengths. And when the wavefront, what is the light consisting of the waves with the same amplitude in the crest and throws, you know, same amplitude, the encounters an obstacle, it changed the waveform, and the energetic level changes, and constructive and destructive interferences occurs. And if the overlapping waves reinforce each when they are overlapped in crash, and when they are overlapped and crash and throw, they distract or cancel each other. So we are talking about destructive interferences, and this is quite important in technologies of some companies. For you to know, it's also quite important that the level of diffraction depends how big is the slit or the steps. And you see, if the slit is small, usually as big as the wavelength, the diffraction is the maximum. When the slit is bigger, diffraction became smaller and smaller. And this playing with the slits or the steps is the way how the physicists design their lenses. So you have a monofocal lens and you put diffractive structure on the usually anterior part of the lens, and playing with the height of the steps and the distance of the steps and angle of the steps, you actually optimize and adjusting the slits or steps, and you play with this 100% energy for each company has, and just you optimize for which focus you would like to have the energy based on the aperture what you get. It means pupil. So here you can see that the step high determines energy distribution. This is what I was talking. So if you play with step high, you can just give more energy for far, near, or intermediate focus, or you just play with this, and the step width determines the addition, what you just give to the lens. Just a little bit transfer to your point of view. Here you can see that if there is a high of the steps, some multiplication of the wavelengths, you see that maximum energy is on the first order. So like for far vision, this is MTF. If you just play with steps, you see that the relation between energies and the amount of the light what you get for far, let's say near vision, change. And again, another multiplication of the wavelengths, when you just play with the steps and you just adjust them, you can just get the maximum energy for the near. So this is the basic mechanism how, when you are playing with the steps, you can adjust the energy level for each focus what you want. And this is probably everybody know this is a simulation. Here, this is the difference when you are 100% of energy is delivered to far point for monofocal lens, or you have a bifocal lens. So you have to take this 100% energy and divide it between far or zeros order or first order. And in between, because this is a bifocal lens, between there is not so much light, there is not energy. And this is transferred to MTF, what you are used to see. So this is the far focus, and this is the MTF value for this far focus for the lens. You should know that for the MTF, there are ISO standards for monofocal lenses, but for multifocal lenses, there is not ISO standard how much MTF or how high peak for MTF you have to achieve for far or near vision or intermediate if you are working with trifocal lens. So the trifocality or bifocality, we are mainly talking only based on the clinical outcome from the patients. So as we can see, or we could learn, many companies are working with diffraction because diffraction is great technology to divide the light to 2 or 3 foci. But diffraction has one big disadvantage, and this is loss of light. So in physics, we know that light scatters within an IOL by every diffractive steps, and considerable. And when there are steps, you know, there is a precision, you are producing steps. So each imperfections just also cause the loss of light, but not only quality, but also quantity of the steps are important for the loss of light energy. And here on this schema, you can see that if you have 7 rings or 7 diffractive steps, the shadow lines just represent the amount of light what is out of focus, what you are losing. And this is the 14 steps or rings, and you see that the loss of light, the quantity of this shadow lines is 3 times more. What does it mean? So this is a theory that if we have less steps, we can achieve less loss of light, and we can achieve higher contrast sensitivity, and of course also less dysphotopsia. And this is exactly what is here, the theory, and this is the first simulation what was done in a laboratory, that this is the far focus, and around the loss of light, when you just take a sagittal cross, you see that this around might be a theoretical basis of diffractive IOL halos. And then when you look for different lenses, when you have a lens with 7 rings, when you have a lens 15 rings, 26 or 21 rings, you see that the lens who has the lowest amount of diffractive rings has prediction to have less halos than other technologies. They have more rings. So again, now we just know a little bit about these small steps, what it is. It is actually the way how to just play with the light. So at the first glance, you can see that all these 4 lenses, they have a full optic covered by diffraction, and the lens, this lens has only middle part diffraction, and around the part is refractive. So let's look closer in the table. You see that the examined lens, what I will just show you a little bit more results, is unique compared to all other technologies to the market, because the diffractive part is only on 3 millimeter diameter. It has only 7 rings. And you see competitors have a full optic diffractive, they have much more rings. And what is very important, there is only 1 diffractive array, but with this 1 diffractive array, the technology is able to achieve 3 foci. All other technology needs for 3 foci 2 diffractive arrays, that's mean more rings. So using this, and this is about using constructive interferences. So you see this is a 0 order, this is a peak for far, and there are small lost energies. And this is a peak for first order for near, and this is also the lost energy. And this in the middle, the technology which can utilize this energy and just make a peak from those two, adjusting these two crashed in the same phase, so they just are making plus together, you just can gain intermediate peak without adding any new diffractive structure. If you see here below on the graph, the blue is the lens made by this constructive interferences, so this, and this shadow gray line, this is the pattern. You can see it everywhere, is bifocal lens. When these two small peaks were diminished to zero, this destructive interferences. So there are two technology. One is producing bifocal lens and one is producing trifocal lens. So just go again a little bit more for simulation, how when we have a theory, how we can just see in a real simulation in laboratory. As I can tell you this, you have to imagine that the amount of energy or light for far, and these are small waves, they are just lost, and this is for near, and the small waves, they are lost. So what happens when secondary maxima of the diffractive force coincides? It's not so easy as you saw, because it's much more complex, and amplitude is vectoral quantity. So interference describes the results correctly, and it looks like this. So if these two are just using destructive interferences, you have a near and far focus, and in the middle you have no amount of energy. If you just use constructive interferences, what I showed you, that you use the same wavelengths in the phase, you can just, from this loss of these two forces or two orders, you can create here the amount, or you just can get amount of energy and create a peak for intermediate visus or intermediate focus. So this, you can see the bifocal lens. This is a traditional trifocal lens with near and far focus, and energy created with the second diffractive array in the middle. And this is the technology who uses the constructive interferences. So this is the far focus, near focus, and with constructive interferences, you gain very nice amount of energy in the middle. Just again, transfer to you a little bit more practical of what you are used to look at it. If you look here, this is the lens. This is the middle of the lens, and these are the steps. And this is the through focus curve. So this is far and near vision, near and far vision, and this is intermediate. This is a bifocal lens, so there is no light energy. And if you adjust the steps on the lens based on knowledge what you want to achieve, you gain amount of energy with constructive interferences here, and it's transferred. You can see it on through focus curve as intermediate peak. So this is the technology, just to show you that you can create it without any editing second diffractive array. Very often there is a question about independency or dependency of the intraocular lenses, pupil dependency and dependency of intraocular lenses. Looking to the physiology and looking to the physics, and mainly physiology, we know that pupil is very important in physiological near triad reflex, which means relative meiosis during accommodation. And based on the studies and publication, this reflex does not disappear during aging or even after cataract surgery. There is a small latency of pupil constriction, but it's not changed with the age, and there is only slight decrease and speed. So we think that pupil plays important role. And when you look at different lenses, how the energy light distribution in the pupil, you see all of them are more or less pupil dependent, or more, or all of them use more or less pupil. But if you look again, this is the lens with 7 rings, this is a quadrifocal lens, this is a trifocal non-apodized, and this is a trifocal apodized. And here you can see the near is red. So for near vision, you see that with 7 rings, there is maximum energy for near vision here. But what is very interesting, if you look for far vision, this is the blue. This is here, so approximately 4, 3, 4, 5 millimeter pupil aperture. The 7 rings technology gives the maximum amount of energy for far vision, and of course it's quite clear because this part is purely refractive part, and when the pupil is open, the patient looks mainly through this refractive part. So when you just look through focus curve or energy distribution, we just went further with different simulation and visualization, how lens works when aperture has changed. So there are different simulations were developed to help us predict the light distribution on different diffractive optical patterns at different pupil apertures. And you can see, because this is also, you have to understand that trifocality is always bind to pupil. Here, this is the lens. This is a 3D maps, how to read it. You can see this, here are diopters. This is the spatial frequencies, and this is the amount of the color. So darker color, high amount of the energy. And this is a 3 millimeter pupil. This is a 7 rings lens. And you see that when there is a 3 millimeter pupil, there is approximately very balanced, divided the energy between far, near focus, and there is also quite nice amount of energy, not even lower amount when other technology who is using conventional 2 diffractive arrays for intermediate vision. But when the pupil is open, 4.5 millimeter aperture is open, when the far vision is very important. Look how strong color, how much energy is dedicated to far vision, also compared to competitor. But you see, this is the same lens and it acts differently in 3 or 4.5 millimeter pupil. And this is a little bit zoomed. This is a quadrifocal lens. This is a 7 rings lens. This is one diffractive array. These are 2 diffractive arrays. And you can see here there is not much less amount of energy for intermediate vision than somebody who is using 2 diffractive arrays. And just for you to know that the most important part for vision is below this red line. So actually the amount of energy for intermediate vision is equivalent for both lenses. So now you can tell me, fine, we have a simulation, ray tracing simulation in CMAX, we have a through focus curve, we have wonderful simulations. So what about the clinical performance? Of course, we follow also lens in clinic, and this is the focus curve from the clinic where you see that intermediate vision is fully satisfactory and not too much different to other competitors. But you can tell me, yes, but what we can give more, because these the focus curves are similar for all trifocal lenses. Yes, the hypothesis was better contrast sensitivity. For this, we have a first proof that yes, 7 rings lens has a little bit better impact for contrast sensitivity compared to 25 rings lens, and also the contrast sensitivity is extremely good after cataract surgery, even better. And last but not least, when we are talking about developing or applying clinical application for practice, I would like to little bit talk just few slides about optical aberration and effects on multifocal IOLs, and mainly about an astigmatism. Because we know that when we are working with monofocal IOL, sometimes it's even beneficial for patients to leave small astigmatism to improve depth of focus. But if you look here and you see that only with 0.25 diopter defocus, the MTF drops significantly. As for the multifocal IOLs, it's extremely important to correct astigmatism already from 0.5 or 0.75 diopter total corneal astigmatism. And just to give you again a little bit dive into the science, there was a simulation done with corneal astigmatism only 0.55 corneal the cylinder, the diopter, and you see that as for monofocal without aberration and for far focus there is clear picture. As for corneal astigmatism, as for monofocal or diffractive for far focus, there is not so big difference as for the halos, but if we are just looking for intermediate focus, there is a big difference between monofocal, between a no aberration and with aberration. So you can see here that this might be the cause of dissatisfaction of the patient who are not implanted with toric IOL, and that's why I think each producer should pay attention not only to the technology but also to the platform which should be optimal for toric IOL when we are talking about trifocal and trifocal toric. And we have evidence about this, about the presented lens. So just to wrap it out and take home message. So we know that there are today different technologies and they are coming new and new on the market. Majority of them using 2 diffractive arrays. Each producer is working with the same amount of energy, so it cannot be lost or just regenerate. It's 100% and we have to work with it. One diffractive array using efficiently constructive interference was proven to be sufficient for creation 340. Fewer diffractive steps led to fewer sources of halos during laboratory simulation, and we need more clinical tests to collect the evidence from clinics. So optical aberrations, especially astigmatism, should be considered and treated when the IOL implanted. And last but not least, IOL platform is also very important when producer consider multifocal IOL designing. And I think it's important for all doctors, surgeons, and practitioners to know a little bit more about technologies, to somehow know how to swim in between marketing claims and facts. So we should know more about hypotheses and physical principles. We should know about spatial simulation like PSF and MTF. We have to more work on eye model, and we know, and there was a publication from Dr. Fernandez and a collective about that we can predict already today from eye model how the lens will act and your patient. And of course, the last but not least, the collecting data and clinical evidence and work with this is more and more important when we are talking about premium lenses. Yeah, this is the publication. So thank you very much for your attention.
Alexandra, thank you so much for your lecture. Excellent description of different kind of multifocal IOLs. Now we will continue with Dr. Joaquin Fernandez from Spain. Dr. Fernandez will have 2 consecutive lectures. The first one will be controversies in presbyopia correction IOLs. And the second one will be presbyopia correcting IOLs, learning from clinical evidence. Thank you, Joaquin, for accepting the invitation. It's a pleasure and an honor from King Kalai Hospital to have you here with us. Please go ahead with your lecture.
Thank you very much, Jose Manuel. It's a pleasure. It's an honor to be here with you. Thank you very much. Well, the idea is to share with you our knowledge with multifocality. In the first presentation overall, talking about controversies, okay? Where as multifocal surgeons, we could have some type of controversies coming from some meeting or even from the marketing. We would like to know exactly what is according with the evidence or not, okay? This is our declaration of interest. We have a relationship with Kontur. It could affect this presentation. Well, these are all the ether that we are going to talk about. In first place, talking about the axial length, we can find some papers like this published in cataract refractive surgery that tell us that the positive candidate could be hyperopic patient, moderate to high, and myopic patient, moderate to high. And probably the myopic patient less satisfied than the hyperopic. And in the other hand, this paper tell us that could have a negative candidate talking about the low myopia. So what is the real with that? Well, we collected our patient talking about this 88 patient, okay? And we try to see exactly, divide for the axial length and to see exactly what is this general satisfaction. As you can see here, when we compare very short, normal, and long eye, we don't have any significant differences in satisfaction. It's not statistic differences. And when we also talk about, as you can see here, talk about comparing the far distance, intermediate, and the near in between of this group, we cannot also find any differences. So in the first controversy, the take-home message is we don't have significant differences between axial length and the satisfaction, talking about the quality of vision and its distance, okay? We need to know that we don't have very long eye in our sample, so we cannot find exactly the knowledge for that. The second is the regular astigmatism, okay? We have different papers that tell us that the postoperative astigmatism more than one dioptries could affect the performance of the multifocal lens. So we need to use multifocal toric lens. And we have here another paper talking about below 1 dioptry, it's possible to use spherical. Above 1.5, we need to use multifocal toric. And what happened in the middle? Well, we can see here this meta-analysis published in ophthalmologists that tell us that comparing toric IOLs versus not toric, as you can see in the forest plot, comparing toric IOL versus not toric with relaxing incision, and comparing multifocal toric IOL versus multifocal non-toric with relaxing incision, the performance is better when we use toric IOL. Okay, there's no doubt about that with this meta-analysis. So for corneal astigmatism, more or equal 1 dioptry, it's better to use toric intraocular lens. Overall, we are using multifocality. In third place, we have the high order aberration at 4 millimeters. Can we implant multifocal lenses with high order aberration? At what level? Well, if you use Pentacan, you can see in this paper, in Highlights Ophthalmology, the MAEDA advice. The MAEDA advice tells us that in a 4 millimeters zone with a corneal irregular astigmatism, when we measure the high order aberration, if we have in between 0.3 microns, in between 0.5, we need to have caution. Above 0.5 millimeters, it would be contraindicated, okay? Well, again, what happened with the evidence, what's happened in the daily practice? Well, as you can see here, we implanted in different patients, as you can see. You are seeing here visual acuity defocus curve. And the defocus curve in yellow is the mean of our sample, and the blue line is the defocus curve of the patient that you have above, okay? This patient at the left, you have a high order aberration around 0.3, 0.49, the next 0.5, and the next 0.6. As you can see, below 0.5 microns of high order aberration, the performance is quite similar to the sample, to the mean of the sample. But when we use multifocal lenses in patients with high amount of high order aberration, as you can see in the right hand, you can see how the blue line is below the mean of the sample. So it's going to reduce in this limit. And what happened in the contact sensitivity defocus curve is quite similar, but even worse. As you can see at the right hand, you can see the patient with a high order aberration of 0.6, how the defocus curve in terms of contact sensitivity is so much below of the mean of the sample. So we have a limit in the high order aberration, above 0.5 microns, you have to try not to implant multifocal lenses. What happened with the pupil diameter? It's important for our patient or it doesn't matter? Well, we measure in extreme photopic and mesopic pupil of our patient with a keratograph, and we also measure with a rule with our patient in a condition of 90 lux, is around a low photopic condition. So it doesn't matter. You can measure with a rule, you can measure whatever you want. But you need to know exactly, as Alexandra paper tell us, that is going to affect directly to the defocus curve of our patient. We publish it in refractive surgery, in journal refractive surgery this year. The different model is a prediction model. So the smaller is the pupil, as you can see in visual acuity and in the model at the left hand. And in the right hand, you can see the defocus curve in visual acuity in the clinical practice. The smaller is the pupil, the better is going to be the performance. And the bigger is the pupil, you're going to reduce overall the focus with less light distribution. In the case of Liberty, is the intermediate, okay? And you can see that that occurs also in the defocus curve in contrast sensitivity. We develop an application, is for free, you can use for free in the Apple Store to use in the iPad. It's called QVision Multifocal Lens Analyzer, and you can measure to your patient the defocus curve for visual acuity and also for contrast sensitivity to use for your practice. And this situation also occurs in all the multifocal lenses. Of course, you can see here with fine vision, the smaller is the pupil, the better is the performance, and the bigger is going to reduce, of course, and the patient is going to have complained about this photopsia. So the take-home messages in terms of pupil, the performance is reduced with the increase of the pupil of diameter and special consideration for the focus with lower energy. And what could be the limit? Probably above 3.5 millimeter or more, okay? You need to know the lens, the multifocal lens that you are using, you are implanting to your patient in order to know what is the focus with lower energy, try to advise to your patient, okay? Next controversy is the kappa angle. It's not good. We don't need to talk about kappa angle. It's not correct. It's better to use the concept core mu. Okay. What is the kappa angle? Well, it's the angle created by 2 points. The one point is exactly the middle of the pupil, and the other point is the line of the side. Okay. The lines of the side is well represented in clinical by the first Purkinje reflex. It's called the Werther normal, okay, in the video keratoscopy. But we cannot in clinic middle angle. We can measure this chord between 2 points, as you can see here. The black point is the middle of the pupil. The white is the Werther normal, the first Purkinje reflex. The question is, you know that after the cataract surgery is going to reduce the pupil. This is published, and also in myotic pupil, we have a little decentration to nasal. Okay, it's common. Okay, well, if we have these 2 points in the middle of the first ring, we are not going to have any these photopsias, at least in theory. Okay, if we have the vertex point, the first Purkinje reflex outside the first ring, we could have, in theory, these complaints with deep photopsias. And if we have a little decentration to temporal, that we used to find this decentration because the pupil is decentrated to nasal a little. If we have the multifocal lens decentrate corresponding to the pupil, a little to the temporal, but these 2 points is inside the first ring, in theory, we are not going to have complaints. You can see in this paper that we publish all that you need to know about the kappa angle. It's published in this paper. It's very easy to understand. And we measure exactly what happened in our patient with the kappa angle. Well, in fact, with the core mu, okay? In this paper, we published that we have found Corneal values up above 0.6 millimeter in pentacam without any affection to the visual performance. So the take-home message is that the Corneal had no impact on the visual performance according to our published clinical study, at least below 0.6 millimeter. We have also another controversy with dry eye, you know, and this sentence is very clear for me. I think this is very clear for you also. The problem that you find before the surgery is the patient problem, but the problem that you find after the surgery, this is our problem, okay? So it's very important to know exactly this paper that has been published that we could have a visual complaint after the multifocal lenses induced by dry eye and not from the optical aberration of the multifocal lens. So it's very important to know that between 3.6 to 16 patients have dry eye symptom after the cataract. We need to know, we need not to convert an asymptomatic dry eye in symptomatic dry eye. We also need to know that symptomatic patient we could recover after 3 months after the preoperative value. And we could reduce the dry eye if we could treat before the surgery. But right now, the published that we have seen in literature, the importance that you can see here in the table, the dry eye is reducing more and more. The percentage of complaint probably is because of ophthalmologists. We are taking more care about that, and you need to pay attention to the subjective questionnaire. Most of all, even more than the sign, okay? Because it's very correlated. We have better agreement in unsatisfied patients with the questionnaire, the subjective questionnaire, than the objective measurement. So it's very easy to have a OSD test, for example, in order to see if the patient has complained before the surgery and try not to improve the dry eye. So the same criteria to follow down in this conventional clinical practice with dry eye. And the last, what happened with the corneal laser refractive surgery? We could implant multifocal lens in patients that have been operated by corneal laser refractive surgery. Okay, let's see. We pull in this case, okay? You can see very clear a myopic treatment, and you can see how we don't have any astigmatism. We are going to use a spherical intraocular lens, and we can see the high order aberration at 4 millimeters is very low. It's 0. Almost 20. Okay, there's no problem. It's inside the MAEDA criteria. But let's take a look of the spherical aberration. You can see at the 6 millimeter of the pentacam, you can see a very high spherical aberration, 0.521. Okay. Could we implant a multifocal lens in this case? Well, this spherical aberration is exactly for 6 millimeters. And we need to know what is the mesopic pupil of our patient. And you can see here, the mesopic pupil is 3.9 millimeters. So we can change in pentacam and we can include the mesopic pupil, as you can see here, in order to calculate the spherical aberration. If we calculate the spherical aberration for the mesopic pupil of this patient, you can see how in the right hand, the Z40, the spherical aberration, reduced dramatically. So we decide to implant this multifocal lens to the patient. You can see the discontinuing line, the mean of the defocus curve of our sample. In blue, you can see the photopic defocus curve, and in black, you can see the mesopic defocus curve. And you can see in the visual acuity is even better than the mean of the sample for this patient. And the contrast sensitivity is even better than the visual acuity. So the previous laser corneal refractive surgery should not be a problem, but it's very important to assess the pupil of the patient. Okay, this is our conclusion. The same criteria for all axial lenses, the regular astigmatism, more than 0.75, dioptries need to be implanted by toric multifocal lenses, avoid high order aberration at 4 millimeters, more than 0.5 microns, pupil diameter could affect pupil more than 3.5 millimeters. Special attention, please, to the less light focus. The kappa angle of Corneal was not related, at least at below 0.56 millimeters. The dry eye evaluation is exactly very important, and in the usual clinical practice, after corneal laser refractive surgery, consider the pupil before to measure the spherical aberration. Jose, I have finished with this presentation. If you want, we can continue with the next.
Yes, Joaquin, go ahead with the second lecture, which is presbyopia correcting IOLs, learning from clinical evidence. So go ahead for the second lecture.
Excellent. this is the other idea. In fact, this week I am doing a master of medicine, evidence-based medicine on Oxford. We are doing exactly this. I need to be in Oxford, but because of this pandemic, we are here and close by online. We are developing all the evidence around the multifocality. You know, our declaration of interest. And this is very interesting. Know what is the functional classification of the multifocal lens? You can see on the top, the multifocal lens, in fact, the bifocal lens that improves the near. So the top, we are going to have high addiction and energy distribution to the near focus. Intermediates with the trifocal. The up is the high addiction and energy distribution to the near focus. And then we have the head of lenses. And we have now, the last year, we have now more and more lenses in this family, avoiding the top of the classification. More and more head of lenses, more and more monofocal head of lenses, okay? Well, let's take a look. This is all the model that is current to the 2020 year. You have here all the bifocal lenses, as you can see, all the trifocal lenses. The high in the scale is the more distribution of light to the near vision and the more addiction, as you can see here. In the top is the Control Liberty. In the low is the BSY, Acriva, Trinova, and Versario, for example. And then to the right, we have the head of lenses, all the new, the Atelara, Fine Vision, Triumph, Symphony, IC8 of focus. You need to know that to differentiate, it's very important for you to differentiate the head of lenses based on diffractive profile and head of lenses based on refractive profile. It's very important to know, okay? I'm going to tell you right now why. As you can see in the refractive arm, the Lucidis, the Miniwell, the Comfort, the Wheel, and the Crystal lens. And we have now even more reducing addiction, the monofocal of lenses. You can see here, this year we have the PBT, the SAC of the Santen, the Physio Isopur, and the Johnson & Johnson Inans. Okay, let's take a look. Let's take a look, and it's very interesting. What is the recommendation? We are going to begin from the theory, from the optical band, and then we are going to convert in evidence. Well, Sabini published this very interesting paper in 2016 with a clinical recommendation. He tells us, in myopes, we need high addiction multifocal lenses, and in hyperopic patient, we need a low addiction multifocal lenses. Why did he tell us this recommendation? It's because of that. Take a look of the table of the left. We have here that the higher is the ACD, as you can see, the less is the effective addition. Okay, it's very interesting. You have the 4 millimeter of ELP and the 5 millimeter. As you can see, for a lens that 4 dioptries, the more is the ELP, is the less is going to be the effective addition. So the distance of lecture is going to improve. But this situation is even worse in low addiction, as you can see in the top, in 1.5 dioptries, comparing 4 millimeter of ELP and comparing with 5 millimeter of ELP, we are going to have a dramatic reduce of effective addiction. So the distance of lecture is going to improve a lot. This is the reason it's published by us, okay? This is the reason that we find exactly different visual focal curve for different people, this different peak. And this is the reason for Sabini to tell us that the myopia patient need to have high addition multifocal lenses. This is very important. But Sabini tells us that hyperopic is good to have low addition. Is this real? Well, based on that, if we have a short ELP, we're going to improve the FFP addition, so it will be good. Yes, in theory, it could be possible, but look at that we have published. We can, when we measure 2 lenses with low addition, Alexandra and Versario, we discover, it's published in the Journal Refractive Surgery, we discover that the less the corneal power is, the maximizes the near focus. So you know that the hyperopic patient don't have less corneal power. It has more corneal power, okay? We're going to have a steeper corneal power. So this type of patient, hyperopic patient with high keratometries, is going to reduce the near addiction. So this is the reason that in the theory, we have a clinical recommendation, but in the according to the evidence in this moment, we have different recommendations. So in myopia, we need to implant high addition, but also in hyperopic patients who had card reading high, okay? If we have hyperopic patient with flat card reading, we could implant low addition, but in my humble opinion, it's not used to find this type of patient. And why the high addition matter? Okay, we have this balance right now in the marketing. We have a trend trying to reduce the addiction of the lenses. Okay, at the beginning we began to have a spectacular independence, try to be center of the patient need. We have a meta-analysis that tell us that the patient, when they are going to be operated, they don't want to use near glasses. And on the other hand, we have the evolution centered on marketing. Okay. That they are reducing the near vision and improving the intermediate. What is the reason? Only to improve the intermediate vision? No, it's because of we are going to see that in theory, improving the intermediate vision and reducing the near vision, in theory, is going to reduce the dysphotopsia. But let's see. First of all, we need to know this sentence of Albert Einstein that energy can neither be created nor destroyed, rather it can only be transformed. So we are going to have the 100%, and you need to know, you need to decide when you want that energy in the defocus curve. Right now, you have the lighting versus the pupil versus the task. And we used to see this type of distribution in between of different lenses, okay? You have the percentage of this light distribution for different focus, blue, red, and violet. And you can see here at the bottom, the millimeter of the pupil, okay? More or less, you're familiar to this information, but it's not really useful for us because when we discover, for example, this focus curve, we cannot have the idea of what is the measure of the pupil of this patient. Is 3 millimeter, 2 millimeter, 5 millimeter? So we need to take decision in our daily practice to know exactly what could be the behavior of the performance of the multifocal lenses in different pupils. So we published this prediction model, as you can see this year in general refractive surgery, that in the visual acuity and the contact sensitivity, you can see exactly what is the performance. That's this prediction model. So the smaller is the pupil, the better is going to be the performance. This is in all the lenses, but this is being published for the Liberty, okay? And you can see here that the model gives us worst scenario that in contact sensitivity that we have found in the clinical practice. This would be for a lot of reasons. Of course, we can find different amount of spherical aberration, different amount of other parameters that would affect the performance. But more or less, this is the idea. What is the behavior? What is the idea that Alexandra, for example, tell us of the behavior of the performance of the lens? This lens is made, but when we have pupil for reading, when we read, we reduce, we have a meiosis, convergence, and accommodation, you know, of course, with the pseudophakic patient, we don't have accommodation, but we're going to reduce the pupil, and in theory, and it's measured in our patient, we are going to have a high amount of near and intermediate vision. But discover that when the pupil is bigger, and what happened in mesopic condition, for example, in the task around night driving, we're going to give more distribution to the distant vision, and we're going to reduce the near vision. This is the idea of only have 7 ring, and this is the idea to reduce the halos, the dysphotopsia, without losing near vision. In our condition, is going to give us a very good experience to our patient when we tell them what is going to be the performance of the lens. We have different papers. Alba Bueno tell us that avoiding how to decrease the dysphotopsia. Alba Bueno tell us in 2017 that avoid high addition bifocal and use it trifocal instead of bifocal. Okay. Roda Elevation tell us that avoiding neurotic personality, we know by experience, but this paper is very interesting of Escandón Garcia that tell us that be careful with the head of lenses based on diffractive platform, because those does not seem to be a solution because of the rings is going to give us sound in terms of these photos, okay? Right now, we don't have evidence enough to know if the new mono EDOF lenses reduce or not the symptoms of dysphotopsia. Could be theoretically, but we don't have any evidence. But we know exactly, for example, Dr. L.Alio published and written this paper based on the allometer of Gonzalo Mejome and tell us that the light distortion index is a parameter that gives us the idea of the dysphotopsia in different patients. Tell us that, for example, with Symphony, we do not have a reduce of this parameter in compare with trifocal lenses. So if we know this evidence and we compare here the near vision that is reduced, really reduced comparing with trifocal lens, probably we need to ask ourselves if we need to reduce the near vision, try to reduce the dysphotopsia that the evidence is telling us that the EDOF diffractive lenses are not reducing the dysphotopsia. Probably if you want to improve the intermediate vision, it's good enough for EDOF. But if you are using EDOF lenses trying to reduce the dysphotopsia, this is not based on evidence, okay? And caution also with diffractive EDOF because the color contrast could be affected. We know, but this presentation in ESCAR in 2019 that in diffractive EDOF, we have a high percentage of the red light and reduced to blue light for distance and in opposite, okay? With people that could live with color, like picture, graphic design, something like that, could affect this situation, okay? It's not measuring, it's only optical bend. We don't have evidence, but take advice of that. What is the profilometry of the different lenses? Well, we have right now, we have different monofocal lenses, mono EDOF and EDOF. The profilometry is the profile of the lenses when we take out the spherical lens, the power, okay? As you can see, the monofocal EDOF, you have a little peak in the middle, at the left, at 0 millimeter, try to improve the spherical aberration, and we compare with mini-well, is higher, the EDOF. Say, well, when we compare monofocal EDOF with EDOF, this amateur of improve of curvature is a little less, okay? And we have different mono EDOF in the literature right now. As you can see here, this is the Santen, this is the alcohol lenses. Well, this, you know that you can improve a little the intermediate, not as good as the EDOF lenses, and we don't know information enough about the dysphotopsia, okay? And for last, long term, we are going to plant lenses for a long time in our patient, and we need to know not only the optical quality, but also the material and the behavior with the PCO, okay? You can compare, we compare these two type of lenses. It's exactly the same material, but it's the different profile of platform. And when we compare, you can see here how the optical, the pacification of the capsular posterior is less in the right with Liberty than Alsafit. And this is quite similar when we compare the contrast sensitivity, the focus curve, in comparison, in the left, is reduced after a year. When we compare with Liberty, that is quite similar after a year, and this is because of the capsular pacification. In conclusion, the effective addition of the multifocal lens can vary depending on the eye biometric parameters. We need to know exactly in what profile. The prediction model can help us to have a wider information about multifocal lenses. The EDOF lenses have not demonstrated to reduce dysphotopsia, and overall the diffractive, the new model EDOF need to give us evidence about that. And the long-term performance is exactly something that we need to care about our patient. And thank you very much for your kind attention. And that's all, my dear Jose.
Thank you so much, Joaquin, for a beautiful lecture. Now is the turn for Professor Sathish. Professor, can you hear me?
Sure, I can. Can you hear me?
Yes, we can. Perfect. So you're ready to share your screen with us?
Okay, first of all, thanks everybody. Thanks to Dr. Vargas for inviting me, and thanks to everybody who has tuned into this Global Education Forum from King Khalid Hospital. I'm going to be speaking about supplementary intraocular lenses and its clinical applications. The supplementary lenses go by different names. They can be called as piggyback lenses or secondary intraocular lenses or add-on lenses. These are lenses which are typically designed to be inserted in the ciliary sulcus, which means they have to be specially designed. We'll talk about that a little bit later. And these are primarily done to correct residual refractive errors, either with monofocal lenses or to provide a secondary presbyopia solution to patients who have had monofocal lenses in the past. Only in the last 10-15 years, industry has developed these kind of special supplementary or secondary intraocular lenses. Prior to that, we surgeons were using two intraocular lenses inside the capsular bag to produce a piggyback lens. And one of the complications which we had with these was what was called interlenticular opacification, where both these lenses, since they were placed in the capsular bag, the lens epithelial cells from the capsular bag equator started to grow between these two intraocular lenses inside the bag and produce this new complication called ILO. And this was a big problem. So now currently we have got 3 manufacturers across the globe who can produce these special secondary intraocular lenses or supplementary intraocular lenses. The first one is in no particular order. First one is the Rayner lens, which is called the Sulcoflex. The second one is the add-on lens from the first cube, Contur. And the third intraocular lens is a lens called Reverso, which is produced by a French company called Crystalens. So these lenses are specially designed to be placed only in the ciliary sulcus and not inside the capsular bag. And for this lecture, I'll be restricting myself to talk about the first Q Contur lens, which I've got a reasonable experience with. As you can see from this slide, these lenses are got 4 haptics, but they've got a square design, but the edges are not sharp edges. As you all know that to reduce posterior capsular opacification, the lenses which are implanted inside the capsular bag has to have a sharp edge to reduce the amount of PCO. Whereas the lenses which are designed to be placed in the ciliary sulcus have got a rounded edge so that they don't have a sharp edge and they don't rub off the iris pigments from the posterior iris pigment epithelium, and thereby reducing the amount of secondary pigment dispersion glaucoma. And because of these 4 haptics, they have got a non-torque design, which means it gives an excellent rotational stability, which is important when you're dealing with toric supplementary lenses which are placed in the ciliary sulcus. And most importantly, they have got a convex concave optic. So it is concave on the posterior side where it is in contact or where it is in proximity to the primary lens in the capsular bag. And it is convex on the anterior surface where it is in close proximity to the posterior surface of the iris. And the other great advantage is these lenses can be placed through a very small clear corneal incision, and also they are reversible. If these lenses have to be explanted, it's as straightforward as implanting them and does not have any higher risk profile compared to explanting a primary lens from the capsular bag. So this is an animation showing the 4-point haptic fixation giving a non-torque stable platform. And on the bottom left-hand side, you can see this convex concave configuration I talked about, where it is convex on the posterior surface so that there is a good gap between the secondary lens and the primary lens, and there is no physical contact. And because it has got a square design, it does not cause any iris capture, which is very important because these lenses are in close proximity to the iris surface. So this is a human cadaver study which we performed where we took pseudophakic human cadaver eyes and we dissected them at the equator. And this is the Apple Miyake view where we have got the special lens holding platform on the surface where we place this human cadaver eyes. And at the bottom of the table, you can see the Apple Miyake camera. And on the top is the standard operating microscope camera. And this is the view which you get from the Apple Miyake view, which is like, imagine yourself lying down on the vitreous cavity and looking on the posterior surface of the IOL from the vitreous cavity. So these are the ciliary processes which you see across 360 degrees. And in this example, in this cadaver eye, we have got a plate haptic IOL in the capsular bag, and you see a lot of sommering ring in the periphery. And in this example, it's a 3-piece posterior chamber intraocular lens within the capsular bag. Once again, you can see a lot of sommering rings of peripheral cortex. And this lens on the left-hand side is the plate haptic, is the add-on lens, which showing that irrespective of the size of the diameter of the ciliary sulcus, these lenses are extremely flexible haptics, so they can either expand or they can flex themselves to fit the ciliary sulcus diameter. So on these human cadaver eyes, we did anterior segment OCT. Just to give you some orientation, we have removed the cornea. So what you're seeing is the ciliary processes, iris, primary lens in the capsular bag, and the secondary add-on lens in the ciliary sulcus. And with a digital caliper, we have measured the distance between the posterior surface of the add-on lens on the anterior surface of the primary IOL in the bag. And in this example, you can see the distance is 1.24 millimeters, showing that once again, this convex concave configuration gives a good distance and a good gap. And this study was published in 2017 in the Eye Journal, showing that irrespective of the primary lens in the capsular bag, this secondary add-on lenses in the ciliary sulcus give a good stability in the ciliary sulcus. And these add-on lenses come in different optical designs. You could just have a standard monofocal, which is seen on your left-hand side of the picture. Then you can have a trifocal on the same platform. Then you can have a monofocal toric, and you can also have a trifocal toric. So on the same platform, you can have different optical surfaces depending on what you want to correct. For example, if somebody has got a residual refractive error after a monofocal IOL, and you can correct them either with a refractive add-on lens or a refractive monofocal toric, or if somebody has got a monofocal intraocular lens and now they want a presbyopia solution, then you can give them a secondary add-on lens, either a trifocal or a trifocal toric, thereby offering them presbyopia now. So just to give you a little bit more information on the optical design of this trifocal add-on, it is very similar to the primary trifocal. It has got a trifocal diffractive refractive design. It has got only the central 3 millimeter, which is apodized diffractive platform, and it has got 6 apodized diffractive steps on the anterior surface of the optic, and it is apodized in the sense that the height of their diffractive steps decreases from the periphery towards the center. And the add-on lens has got a 3 diopter power at the lenticular plane, which translates to 2.25 diopters at the spectacle plane. And similarly, the intermediate add is 1.5 diopters at the lenticular plane, which translates to 1.25 diopters of intermediate addition at the spectacle plane. And these lenses can be specially calculated on an online calculator platform like you would traditionally do for any of your torics or your trifocal lenses. The only caveat to remember is because these patients are previously pseudophakic, you need a very stable subjective manifest refraction. This is one of the key parameters which is required to plug in while you're calculating these lenses. And also, most importantly, you need a pseudophakic biometry. So when you're doing biometry on these patients, you need to go back to your IOL master or a LensStar and change the parameters from a phakic to a pseudophakic mode so that you get the pseudophakic anterior chamber length and also the pseudophakic anterior chamber depth, which is all primary parameters to calculate the add-on required IOL power. So at the bottom, you can see under the result, you can see in this example, we have calculated add-on monofocal lens, which is spherically equivalent of minus 2.75 diopters. So this the surgical technique is very simple. You can see the primary IOL in the capsular bag. We are injecting an OVD to increase the space in the ciliary sulcus. So this is the add-on lens, which is placed in the injector cartridge, as you would traditionally do with any of the standard intraocular lenses. And as I said before, this goes through a standard 2.2 millimeter clear corneal incision. It's a very straightforward procedure, well within the skill set of any anterior segment surgeon. And this is an add-on lens, which is a monofocal toric in this example. All the 4 haptics are placed inside the behind the iris, and now you can see the lens is rotated so that the toricity is placed in the platform where it's required in the meridian, and then make sure that the OVD behind the IOL is removed and some Mayacol is injected to induce meiosis. And it's a very straightforward procedure. It takes literally about 10 to 12 minutes or less than that to do. I'm just going to share with you some of the results from Professor Batusita from Spain, where he looked at the prospective case series of 16 pseudophakic patients of 16 eyes of 10 patients. 6 of them underwent bilateral add-on trifocal lenses, and 4 of them had monocular implantation of these trifocal lenses. These are patients who have primarily had monofocal lenses, where the secondary add-on trifocal lenses was done to give them a presbyopia solution. That's the mean age, and this cohort was followed up for 6 months. That's the postoperative refraction, and at the bottom you can see the unaided distance, unaided intermediate, unaided near, all very good results, and the results are shown in logMAR. And these are no changes to the preoperative to the postoperative intraocular pressure. Once again, none of these patients require any peripheral iridotomy. And that's the corneal endothelial cell density between pre-op and postoperative period. And also the anterior segment OCDs showed no change to the angle structure. One important caveat to remember is all these patients should have a minimum anterior chamber depth of 2.8 millimeters when measured from the corneal endothelium and not from the epithelium. So that's an important criteria to remember. So from when measuring it, the anterior chamber depth, you have to measure it from the corneal endothelium to the anterior lens surface. And all these patients are suitable if the anterior chamber depth measurements is 2.8 millimeters or more. And this is the defocus curve for these patients who had the secondary add-on lenses. Once again, showing the nice peak for distance, intermediate, as well as near. And this defocus curve with this secondary add-on lenses is when compared to the primary add-on lenses, which is the fine vision in this example, is very similar defocus curve. And the patient satisfaction was very good following this add-on lenses as presbyopia solution. So when you come with dealing with refractive error for patients who have had primary surgery, the options you have is either you can correct the refractive error with contact lenses or with spectacles, if that is doable, or you can correct them with laser refractive surgery, either in the form of PRK or LASIK, or otherwise you have to deal with them with intraocular lens exchange, or the easiest option to consider is an add-on lens, where once the refraction is stable, then it's a much easier procedure to perform than doing a primary intraocular lens exchange, which, as you know, could be much trickier. So I'm just going to end this presentation with one case report. This is a patient of mine who was a 65-year-old female who was interested in refractive lens exchange. That was a preoperative refractive error. She was mildly hyperopic and with presbyopia. So that's the preoperative measurements, where you can see the axial length on the lens star of the right eye and the left eye. And that's the calculated trifocal intraocular lenses. She underwent Zeiss 80 Lisa trifocal intraocular lenses in both eyes. So the right eye surgery was done in May of 2018, and a week later, she had a left eye surgery done. Both the procedures were uneven full, but right eye had a refractive surprise. So she ended up with a big myopic shift with some residual astigmatism. And slit lamp examination showed she had capsular back distension syndrome because of residual viscoelastic material left. That's the shine fluke photography showing the anterior lens surface, posterior lens surface, and the distension of the capsular bag with some fluid present behind the IOL. So she underwent a Yagley posterior capsulotomy to drain some of the fluid. In spite of that, the myopic shift, which was caused by the fluid retention in the capsular bag, did not go away. So that was an uncorrected distance visual acuity in the right eye, which is 619, and in the left eye was 6.5. Binocular uncorrected was 6.6. Patient was happy. So at this point, we decided not to do anything, and the patient was discharged. Subsequently, a few months later, she came back complaining that the right eye uncorrected distance was not very good. And you can see that vision was 624 in the right eye, and manifest diffraction at this point once again showed a big myopic shift with some residual astigmatism. So at this point, we decided to implant an add-on lens. So she underwent this calculation, and at the very bottom of this calculation, you can see the calculation called for an IOL power of -3 with a 1 diopter of cylindrical correction. So in March of 2019, she underwent a piggyback toric intraocular lens implantation to correct this residual refractive error, and postoperatively uncorrected distance visual acuity retained to 6.6, and the patient was very, very happy. So currently we have this new technology from 3 different intraocular manufacturing companies, which can correct residual refractive error, or even this could be an option to correct in complex eyes, like patients who have had keratoconus, have got residual refractive error after the monofocal lenses, or patients who have had post-corneal transplant, where they have this residual refractive error, which could be effectively corrected with these add-on lenses. And the new area where we could use the solution is patients who have got no residual refractive error. They have been happy with their monofocal lenses, but now they want a presbyopia solution. It's much easier to implant a presbyopian secondary IOL without trying to explant the primary IOL in the capsular bag. So these new supplementary IOLs from these manufacturers have now gives us new tools to correct this residual refractive error for any of our patients who will require them. Thank you. If there are any questions, I'm happy to take.
Thank you so much, Sathish, for your beautiful presentation and providing this new alternative to correct either refractive errors or presbyopia as well. Let me ask you one question. We don't have that much time because this Zoom meeting probably will end very soon. We have been for about 2.5 hours. Let me ask you one question. Have you had any pigmentary glaucoma? And the second will be, have you implanted this lens as a monocular alternative, or you always implanting in both eyes?
Regarding your first question, I haven't seen any pigment dispersions, at least in 3 years of follow-up. The key is to make sure that these patients have a good anterior chamber depth, as I said before, and they don't have any pre-existing iris problems. The second thing, regarding the second question, I've implanted them monocularly. Only so far there has been no need to implant them binocularly. Most of my experience has been with correcting residual refractive error in patients with post-corneal transplants or with refractive surprises.
And the other question is, which is the highest cylinder that you can correct with this lens? Can you customize this lens?
You can customize this lens. The lens can be customized, at least from Medicontour. They are able to pretty much tailor and customize the amount of astigmatism or cylindrical correction which you require. The highest I have done is probably 13 or 14 diopters of cylinder to correct a post-PK astigmatism.
Oh God, that's very, very high.
Yeah.
Okay, let's see how much time we have. Check for the Q&A and see some of the questions that are here in English and some of the ones that are in Spanish. So the discussion is open for Joaquin, Alexandra, and Sathish. Please read the question and answer the question directly to the audience.
Okay, I'll pick up the last 2 questions. Is the IOL calculation formula universal? It depends on each company. Each of them have proprietary algorithms to use for calculating the IOL power, especially when it comes to the secondary add-on lenses. So if you're going to use from Rayner, you have to use their platform. If you're going to use from the crystallines, you have to use their own platform. Unfortunately, none of these companies give this proprietary information on what are the parameters which they use. At least for Medicontour, I know what they use, and the ones which I've shared with you on this presentation is one which the Medicontour uses to calculate the add-on IOL powers. I'll just take one more question, and then I'll pass it on to Joaquin. You forgot to mention the use of ICL as a piggyback correction. I'm aware of that, but unfortunately, it's not licensed to be used. That's the reason why I didn't mention it. And secondly, I don't have any first-hand experience on using ICL as a piggyback option.
Okay, there is a question for Dr. Fernandez. Joaquin, can you read the last question? It's a question either for you or Dr. Sathish.
The add-on is compatible with any kind of different in the back material? Sathish?
Right. I see oh yeah, they got more questions here.
Okay, the add-on, all the add-ons have to be hydrophilic for the same reason. It has got much better biocompatibility with the iris. And secondly, because of this reason, all the IOL manufacturers who are currently producing the secondary add-on lenses, they're all hydrophilic lenses.
This is a very nice question here. If you will be worried about the long-term implications of capsular back dislocation.
That's a great question. I didn't have a chance to cover all of these. One of the contraindications for putting these add-on lenses is capsular bag instability. So if patients have got pseudoexfoliation, or if they're posterior vitrectomy, or if they had a complicated primary capsular surgery, then these will not be good candidates to consider add-on lenses. One of the important criteria is an uncomplicated primary cataract surgery. So which means the capsular bag zonular complex has to be stable before considering putting in any of these lenses.
Okay, let's see. Joaquin, there is a question for you here, but it's incomplete. Yeah, they didn't finish here. The other question here for either for Joaquin is also, do you think that it will be able to implant it add-on over the sulcus with a 3-piece IOL as a previous implant? That means that there is not going to be any intraocular lens in the capsular back. There is already a lens in the sulcus, and the question is if you can put the add-on over on top of this one.
Absolutely not.
Okay. Let's see more question here. Available powers. There's another question for Dr. Suarez, regard from Dr. Suarez from Dominican Republic. Which is available power for regular and toric for astigmatism correction?
Sasha, I think you need to unmute yourself. Sorry, Dr. Vargas, is that question for Dr. Kontur?
Yes, it is. Yeah.
Yes.
I mean the normal values for add-on toric is up to 5 cylinder, but this is because it's usually just in capsular bag lenses. Of course, we can develop even up to 20. For add-on, we have a normal ratio because it is just like correction up to 5. But of course, the special lens order we can just develop more.
There is another question here. If there is a role of the add-on trifocal in patients with potential posterior pole pathology, for example, normal macular in a diabetic patient.
Sorry, I didn't understand that question. Could you use?
Yeah, if you can use this add-on trifocal in patients, let's say that you have a diabetic patient and you want to implant this add-on trifocal. Is the diabetes a contraindication for this?
No, but the diabetes itself is not a contraindication for add-on. But obviously, if they have diabetic retinopathy or maculopathy, then the primary trifocal technology may not be a good option for them. But diabetes per se is not a contraindication for putting in an add-on IOL.
There's another question here from one of our consultants. If you have any experience using the add-on post PKP patients?
Yes, as I said before, that has been my one of the most important indications for using add-on lenses is to correct residual refractive error in patients who are pseudophakic and post-corneal transplant.
Are completely mobile. Let's see. This is a question for Joaquin. Is there any correlation between corneal power and MF efficacy?
Yeah. Yes, we were talking about that in the presentation. So the higher is the corneal power, we are going to have a reduction of the performance of the multifocal lenses. So this is one of the reasons that in a therapy patient that is used to have a high keratometries try to have multifocal lenses with more addiction.
Good. Let me see. Let's see. You guys can check and see if there is any question addressed directly to you guys. Okay. Let's see. There are more questions here.
Yeah, actually, there were 1 or 2 questions regarding the company question. So I type it. I answered already by typing.
Here's another one here. Is there chromatic inversion correction for far or just for near?
Chromatic aberration? No, there's not in our technology. We are not working to correct chromatic aberration, but there are many slides what I could show that chromatic aberration, and again marketing claims it's not exactly what is happening in the practice, and I would not even start in this because I think there is much more research needed, and we claim that we have very high very low chromatic aberration because of the property of the material, because of very high Aber number, what reflects in high level of contrast sensitivity in diffractive IOLs as well. But during the diffractive technology, there is a reverse set of the light's colors, which are corrected than the cornea. It's quite complicated, but we do not work with chromatic aberration in our technology, and it's not 100% the fact what the companies are claiming about working with chromatic aberration in diffractive lens. It must be a little bit more studied and bring to the market with facts and evidence.
Yes, in fact, Jose?
Yes.
Can you hear me?
Yes, I can hear you.
Yes, in fact, I think that the presentation that we have at the beginning was focused on that, no? Try to differentiate the marketing messages from the optical bound, from the evidence. So we have more and more possible controversies. Try to, I don't know, in a second opportunity, Jose, talk about that, no? Because, for example, we are listening more and more that we could find multifocal lenses that could control the chromatic aberration, and what could be the performance in our daily practice to our patient. It would be very interesting, but we need to explain adequately. And all these questions that the people have, and all the questions that the marketing could give us in the messages, you could give us, and even we can create a review over these items, over these controversies that we presented before.
Let me ask you one question for all of you without talking about any commercial IOL. Which will be the ideal platform that you will use in a patient post-refractive surgery?
Post-LASIK, corneal laser refractive surgery?
Either LASIK or PRK.
And what would be you looking for? In what terms? In what term exactly?
I want to be free of glasses.
Free of glasses?
Yes.
And
every single patient after refractive surgery, they're very demanding patients. Even before they get refractive surgery, they're very demanding. Then after they get refractive surgery, either they develop cataract and they want surgery and they don't want to use glasses, or they have presbyopia and they don't want to wear glasses. What will be your approach after this patient after refractive surgery?
Yes, we need to focus in, as we talked before, in two parameters. It's the higher aberration and the spherical aberration. Okay, we know exactly from the evidence that we don't need to cross the line of the 0.5 microns with a higher aberration. Below 0.3, the performance is going to be excellent. Between 0.3 and 0.5, it would be good enough. But above 0.5, you need to exclude this patient, okay? And you also need to put the focus on the spherical aberration. But we were talking about, Jose, that we need to put the attention in the pupil, the mesopic pupil of the patient. So we need to measure the spherical aberration, the higher aberration, with the diameter that the patient have for the pupil in mesopic condition. So then you come to select, but it's not an issue of what platform could be better in terms of optical quality or something like that. We need to measure overall what is the red line, that we don't need to cross in this type of patient.
Sathish?
I agree. I think it's there is no one magic lens which fits for all. It pretty much depends on the ablation zone, the pre-existing corneal condition of the patient, and the quality of vision the patient is willing to compromise. I think what Dr. Fernandez explained makes a lot of sense and a lot of science, and that should be the factors to find out whether somebody is suitable or not.
Well, I think that before this Zoom cut the meeting, I want to thank everybody for this beautiful symposium. Alexandra, Sathish, Joaquin, on behalf of King Kali Eye Hospital and Global Education Forum, we want to thank you for your beautiful presentations. Hopefully we can make another meeting very, very soon, and with more speakers. And as you say, Joaquin, we can cover more about this new technology. Thank you so much.
Thank you.
Thank you very much, Jose. It's absolutely incredible, all the things that you are doing for the community, scientific community all over the world with all these webinars. So thank you very much.
It's already 1 year doing this every week.
Thank you very much for your effort, my dear friend.
Excellent. Thank you so much. Thanks for having me.
Thank you. Thank you for accepting the invitation. We really appreciate it.
Thank you very much for
Alexandra.
allowing me to attend this. Thank you.
Thank you. Joaquín, thank
Bye,
you.
bye.
Gracias. Por ahí te mando saludos, Marco Ríos.
Ah, qué bueno, Marco. Encantado.